Okay, I think maybe we'll go ahead and get started. Welcome to Pediatric Grand Rounds. Thanks for coming. I'm Iris Borowski from the Division of General Pediatrics and Adolescent Health, and it is my pleasure to introduce our Grand Round speaker today, Dr. Annie-Laurie McRee. Annie-Laurie just joined General Pediatrics and Adolescent Health as a faculty member just over a year ago. To give you a brief background, Annie-Laurie received her undergraduate degree in education at Millsaps College in Jackson, Mississippi. She earned her master's in public health from the University of Michigan and her doctorate in maternal and child health from the University of North Carolina in Chapel Hill. Along the way, she gained over a decade of practical experience in adolescent health, directing a community-based sexual and reproductive health program for young people. Annie-Laurie first joined our division as a postdoctoral fellow in adolescent health. After completing her fellowship here, she served as faculty at the Ohio State University for a couple of years, and we were thrilled when she returned here last August to rejoin our division as faculty. Annie-Laurie's research focuses on adolescent preventive services and vaccinations. Her work has yielded over 60 peer-reviewed publications and numerous national presentations. Over the past decade, she has conducted multiple studies on human papillomavirus, HPV, vaccination attitudes and behaviors among diverse populations, and this research has informed her further work to develop and evaluate innovative interventions to increase HPV vaccinations, including among vulnerable populations of youth. She'll share some of her expertise and her work in her presentation today. Please join me in welcoming her.
Find all my buttons, my glasses, to get going here. Thank you for inviting me here today. I'm thrilled to share some of our recent work with you. Unlike some of other presentations, instead of talking about just a single study, I'm going to be looking across sort of a body of research that we've been doing for the past several years around HPV vaccination, particularly behavioral aspects of vaccination. And to get things started, I have no relationships to disclose. To give you an overview of what we'll be doing today, I'll talk very, very briefly about HPV. About HPV vaccination, we'll go over some guidelines and some trends, and start focusing on correlates of vaccination, because this is really important when we're looking at how do we identify modifiable targets for intervention. We'll talk about recommendation best practices, and then just touch a little bit on what it means to look beyond recommendations when we're trying to increase HPV vaccination. Okay. So as I'm sure many of you know, HPV is the most common sexually transmitted infection in the US. About 14 million new infections occur each year. And most importantly, about half of these occur in young people ages 15 to 24. These can lead to several adverse outcomes. And this diagram, which comes from the President's Cancer Panel report that came out in 2014, shows these additional outcomes. At the base of the pyramid, you can see that genital warts are the most common HPV-related disease, and there are about 340,000 cases a year in the US. And while cervical cancer is the most common cancer caused by HPV, the virus also plays a significant role in other anogenital cancers in both men and women. You can see these in order of incidence as we work our way up. These include cancers of the vulva, vagina, and anus in women, and cancer of the anus and penis in men. HPV-associated cancers of the oral pharyngeal region are a growing problem in the US. And these cancers have more than tripled between 1998 and 2004. So at this rate, by 2020, they will exceed the cases of cervical cancer, which really points to the importance of looking at HPV and HPV prevention among both males and females. So I'm not going to spend a lot of time talking about the vaccine itself, but want to provide a little bit of orienting information and a brief overview of vaccine and vaccine coverage. Over the past decade, there have been a few different HPV vaccines that have hit the market in the US. So this chart demonstrates these types included in each vaccine. Going from the top line, the bivalent vaccine targets cancer-causing HPV types 16 and 18. Those are shown in turquoise. and these cause approximately 66% of cervical cancer cases, and most cases of anal cancer. The quadrivalent vaccine on the next row adds 2 additional cancers into this, and these are types 6 and 11, which are responsible for the vast majority of genital warts. You can see those in orange. And the 9-valent vaccine protects against those 4, plus an additional 5 cancers that cause approximately 15 additional % of cervical cancers. So while no clinical trial data are available to demonstrate efficacy of the vaccine for prevention of oropharyngeal and penile cancers, because these are attributable largely to HPV type 16, the vaccine is likely to offer protection against those as well, except for I like to be really careful. I hear people saying HPV vaccine can prevent oropharyngeal cancer, and we simply do not have those data. So over the past decade, a few different vaccines have become available. As I mentioned, current recommendations are a little bit different for girls and boys. There are 3 vaccines available for girls, a bivalent, a quadrivalent, and a 9-valent that we just discussed. For both genders, the vaccine is given in 3 doses over the course of 6 months, ideally. It was first approved for girls as a routine administration in 2006. With boys, we rolled it out a little bit differently. Not only did it come later in 2009, but at that point it was just a permissive recommendation. And that recommendation was just indicated for prevention of genital warts. It wasn't until 2011 that it was recommended for routine administration. I want to touch on this real quick. So right now we say that there are 3 doses required. Last week, October 12th, the FDA actually approved 2 doses of HPV vaccine for younger adolescents. And I can talk more about that in a bit. It is not an ACIP recommendation yet. So ACIP is the Advisory Committee on Immunization Practices. It's not recommended for that yet, but it has been approved by the FDA. So as far as when do we administer it? Routine vaccination at ages 11 to 12. Ideally, all preteens should finish the series by their 13th birthday. It can also be started as early as age 9. Girls age 13 to 26 years of age and boys 13 to 21 who haven't started or finished HPV vaccine should also be vaccinated. And this is commonly called catch-up vaccination. For boys, vaccination is also recommended for routine administration to men through age 26 who are in certain high-risk groups, and that includes men who have sex with men and those who are immunocompromised. So I also want to watch our language here. We refer to this as catch-up vaccination, but really, people who get vaccinated after age 13, they are late. They are off time and overdue. And our language has a lot of power. So we hear people talk about, oh, it's important to get the vaccine early. 11 and 12 is not early. 11 and 12 is the recommended age. And so these words carry power with our patients and with the public. So these are data that came out about the past month and a half ago showing vaccination coverage in the US among adolescents 13 to 17. So these are all kids who should have completed the series at that time. All right, so it shows 2 different vaccination outcomes, and these are drawing on data from the NIS Teen, the National Immunization Survey Teen, which uses provider-verified vaccination outcomes. So we see in gray is initiation, so that's having received at least 1 dose of HPV vaccine. We can see that nationally, 63% of females have initiated, and it's exciting to see that last year we hit 50% among males. I'm just trying to think that's a glass half full, that we are making progress. We were having very slow uptake among boys. And those gender differences really aren't surprising, given that gendered rollout of the vaccine and guidelines. Among boys, receipt of all 3 doses is really, for both genders, the priority public health outcome, but only 42% of girls have received all 3 doses of the vaccine, and 28% for males at this point. The coverage also varies by state, not just by gender. This map shows initiation levels, and these are just among females. It's very, very similar for males. Those with the light gray area have the lowest levels of uptake, and the darker is the highest, ranging up to about 88%. So you can see that there are also some trends regionally. There are a couple of pockets. So down in the Deep South, we have a handful of light gray, where we're not doing so well, as we do in the Rocky Mountain region of the West. I will also say those are the 2 places I'm from. I grew up in Mississippi and then lived in Boulder, Colorado for 15 years. And so I came from areas that really do not have high uptake of the vaccine. I didn't start out this work as a pro-vaccinator. I wasn't an anti-vaccinator, but the more I learned, the increasingly excited and passionate I am about vaccination. I thought I'd just quickly show where Minnesota is with regards to HPV vaccination. Basically, we're doing slightly better than the rest of the US for 3 of these 4 outcomes we see here. We have 66% initiation among females compared to 63% nationally, and 45 versus 42% for completion. With males, we're actually doing a good bit better. You'll remember nationally it was 50%, but we have 57% of boys 13 to 17 in Minnesota have received HPV vaccine. Our follow-up, so 3-dose series, actually a little bit lower. So we still have some to do here in Minnesota. So I want to point out some trends in vaccination coverage, and there are a lot of data points on this slide. So I'm going to walk us through it. First, I want to point out that the healthy people 2020 goals are 80%. That's why it's in orange on the chart and big. That is the target that we want to hit. The bottom 4 lines in the blues and the reds show HPV vaccine initiation and completion among females and males, respectively. You can see the rate of first and third dose of HPV vaccine for either gender is not nearly as high as the coverage rates for other adolescent vaccines that are also recommended for routine administration to 11 and 12-year-olds. So we're low, but another very important piece of information in this chart is that the strong coverage rates, for example, for Tdap, show that not only are most preteens and teens actually getting vaccinated, so it is possible for us to hit these target rates and achieve better coverage. So being a public health researcher, I am interested in demographic trends, and I'm interested in disparities. We often talk about vaccination disparities, and so I want to talk about what that looks like for HPV vaccination. The gray bars here show initiation among females by race and ethnicity, and the blue shows by SES. I'm just showing data for females. The data for males is very, very similar. One of the things interesting that we don't see the same pattern of disparities for HPV vaccination as we do for many other health services. Instead, we actually see lower levels of vaccination coverage among non-Hispanic whites and compared to blacks, Hispanics, and we actually see the highest level of coverage among Native Americans. We also see that adolescents whose families are higher income or at or above the federal poverty line also have lower levels of vaccination. These are not intuitive, right? Important to note, and there are a few reasons that this might exist. One being VFC coverage, but the other being higher rates of hesitancy among those populations. So the good news is with the coverage that we have, we're already starting to see positive benefits of HPV vaccination at the population level. Population impact of these early and mid outcomes include both the prevalence of HPV as well as genital warts and precancerous cervical lesions. This slide shows the prevalence of the 4 types of HPV that are included in the quadrivalent vaccine using a simple, basically a post-test comparison before and after introduction of the vaccine. And these data come from NHANES. On the left, we can see the prevalence of these types of HPV in the time period right before, so 2003 to 2006. It was 11.5. Compared to after, 2009 to 2012, the period of introduction to the vaccine, it was reduced by more than half. So we are seeing similar trends across these, and that's the good news. We're already having a difference, even with low coverage. But, you knew there'd be a but. The US is still lagging behind other countries. This is just a sampling. But you can see that Australia and England have much higher levels of vaccination than we do in the US. So we still have a long way to go. So together, what we're in that first set of slides is really what drives my current work. I'm driven to understand how we can have a vaccine that prevents cancer. And yet, we have so many young people who are not receiving that vaccine. So early research of our own and of other groups focused on vaccine acceptability, primarily among parents, as they are key primary vaccine decision makers for their children. Most of what I'm going to talk about today is talking about parents. Things might actually work differently for young adults or for adolescents if we were making recommendations directly to them. Okay, so we're seeking to identify modifiable correlates of vaccination, as I mentioned earlier, so that we can inform interventions and ultimately increase vaccination. So listed here are some of the most consistent correlates of vaccination, both in cross-sectional work and predictors of vaccination in longitudinal studies. The attitudes and beliefs of parents, which are what we focused on at the beginning, by and large, they do matter. Perceived benefits of the vaccine are associated with better uptake, but perceived harms and perceived barriers, lower levels of vaccination. The perceived likelihood of getting HPV is also associated, that should be a plus sign, with greater uptake. As are social norms, and this is one place that we do actually see more differences between adolescents and young adults than with parents. Positive social norms are associated with increased uptake. The idea that other people like me or my child are getting the vaccine, or that other parents are vaccinating. And then this last line, anticipated regret, is a construct not that many people have heard of before. We measure it in a couple of different ways. One is, I would regret not getting my child vaccinated if they later got cancer. Have many of you seen the new group of HPV vaccine commercials that have been out? It's really playing up to this. They're showing young people who later have cancer and thinking back about, wow, Mom, you had the opportunity to protect me. And that is really tapping into this construct of anticipated regret. Yeah, no parent. So there are a couple of things that aren't on this list that I think are worth noting, especially because they're things that we tend to go to when we're like, what should we talk to parents about? Knowledge about the vaccine, general knowledge, like, oh, it's recommended at this age, it protects against X, Y, and Z, not associated with uptake. High parent knowledge doesn't seem to make a difference the same way, plus they're pretty high levels of knowledge anyway, for uptake once you throw in these important attitudes and beliefs, okay? The other thing that's not on there are perceptions of effectiveness. In part, that's because parents don't actually doubt that it's effective. Okay. But those are not associated multivariable models. They don't predict uptake longitudinally, but they're the easy things for us to talk about. Let me tell you more about the vaccine, and hopefully today we'll talk about some things that might be more powerful messages for us to get across. The single most consistent correlate, though, across studies, and we're talking about studies with diverse populations, parents of young people of different racial and ethnic groups, rural and urban, rich and poor. The single strongest correlate of vaccination is a provider recommendation. And there was a meta-analysis a few years ago that came out. There are so many studies that have provider recommendation in them, but the average odds ratio, if someone had received the vaccine or not, is 18 across those studies. So this is incredibly powerful. It makes sense. It is a clinical intervention and does require a clinician to administer it, but it really speaks to how critical a provider can be in a parent's decision. And so even though a provider is so critical, many young people don't actually receive a recommendation. And among those who do, it may be weak or ambiguous. So we often use this term missed opportunity when we talk about healthcare and when we talk about vaccination. Around 80% of unvaccinated adolescents had a preventive care visit in the past year. Missed opportunity. 2/3 of those got other vaccines at those visits. So we have huge missed opportunities to clinically address HPV vaccination. We hear a good bit about the idea of parental hesitancy. In fact, it's one of the main things I hear about when people talk about the vaccine right now. Parents are so hesitant to get vaccinated, or at least a population are. But it's not just parents who may be hesitant. Providers may be hesitant too. Generally not so much about the vaccine. Clinicians feel very positively, again, we have a vaccine that prevents cancer. This is incredible. But they may be hesitant to recommend the vaccine, particularly at the target age. This hesitancy is understandable. Vaccination recommendations are happening in a very complex communication environment. I'm not a clinician, but I have a lot of respect for all that has to go on in this visit with a young person and a parent, and with the relationship that you as clinicians are managing within that visit. There are competing demands. And perceiving parents may not be receptive makes it hard to initiate a conversation, particularly one that the provider may worry may be involved and take a lot of time. So one of the things that we found using data from clinicians, actually even here in Minnesota, is that providers are more likely to recommend the vaccine if they have high levels of self-efficacy. So if they think that their recommendation is going to be effective and is going to matter. And that also if they anticipate a positive reception from parents. So given their influence, understanding how providers communicate about HPV vaccination is critical for getting more adolescents vaccinated. And so that's really what we've been focusing on lately. We want to identify what makes a successful or a quality recommendation, because it's not just any old recommendation that will do the job. And so that really brings me to the purpose of what I'll focus on for the rest of the talk today. And that's to discuss communication as a key strategy for increasing HPV vaccination. So there's a lot of research going on right now. I was just at a national conference on HPV vaccination in Atlanta at the end of August with some pretty incredible research, really trying to identify what does make this quality recommendation. My colleague Melissa Gilkey, who is now at Harvard Pilgrim, proposed using 4 indicators, and this study came out there were 2 pieces, fall of 2015 and then this past spring. It made a splash and even showed up in the Onion, which I think might be the height of dissemination. But she proposed using 4 indicators to assess quality. And these were timeliness, consistency, the strength of endorsement, and urgency. In her studies, she used these as separate dichotomous indicators, and using that index, found that only 40% of providers reported using at least 2 of those. And that is actually even a little bit higher than we see when we actually listen to recordings of patient-provider interactions. The good news, though, is that those who gave higher quality recommendations, the parents who received those quality recommendations were much more likely to initiate and complete the HPV vaccine series, and they were less likely to delay or refuse HPV vaccination. So it seems like we could have a cycle here, right? So someone makes a high quality recommendation, they get good reinforcement, their self-efficacy increases. So by using these quality practices, we may be able to reduce hesitancy among parents, but also with that positive reinforcement, also increase provider self-efficacy and decrease their hesitancy. So I want to talk about each of these in turn. What do they look like? And use some examples from our own work, including those studies with clinicians here in Minnesota. The first of these indicators is timeliness. And by timeliness, I mean recommend HPV vaccine at the target age. Again, 11 and 12. After that, you're late. You're overdue. But we find that about 1/3 of providers do not routinely recommend the vaccine at this age. And what's really interesting to me is that 75% of providers don't worry about completion by the target age at all. They say that is not a concern. So these data, I don't want to get too hung up on the disciplinary differences here, but they show the percentage of providers who say they recommend HPV most of the time to 11 and 12-year-old patients. And among girls, we see even among pediatricians, that was just about 80%. So 20% self-report that they're not recommending it most of the time to that age group. The lower levels we see here for boys make sense, given the gendered rollout, and these data are also a few years old. We also collected some qualitative data, and I think they say a lot about how we think about timeliness for HPV vaccination. Something we hear over and over again. These data come not only from providers here in Minnesota, but also a parallel study we did in Seattle. But this idea that you're never actually off time for HPV vaccine. And this idea that the term catch-up is interesting. With other vaccines, everyone gets freaked out, but not with HPV. So this might be in part because of the way those recommendations are framed. Oh, you can get it, but it's really important that you get it before sex and by age 26. So our recommendations haven't been super clear coming from ACIP, but really providers haven't been delivering those and also don't get the idea that it's super important that we do this at an earlier age. The next one is consistency. And when we're talking about consistency, when we're talking about making a routine versus a risk-based recommendation, which ties in a little bit with what I just brought up, 39% of providers say that they use a risk-based approach. So they're more likely to recommend the vaccine to those they perceive are sexually active. Let's look at some data to support that. Qualitatively. So I think if they're sexually active, I probably stress it more. So there are other things, though, that also might indicate risk. This one's interesting to me. I worry that as they get ready to head off to college, it's just harder for them. So they're talking about a risk based on access to care. So it's not just about sex. Both of these are confounded with age. But the idea that if I don't do it right now before they go off to college, so we see a big push among providers to get young people vaccinated before they leave home, before they leave their parents' care. Again, that's late, not on-time vaccination. The third of these qualities was the strength of endorsement. And generally this means to present the vaccine as important. Of course, we don't know exactly how we tell parents it's important. And we have a study right now that just came out of the field where we're trying to look at what messages mean important to a parent. But we can share a little bit here. This is not my most intuitive chart I've ever made, so I will walk you through it. It shows the percent of providers who report that they do not say the vaccine is very important in orange. And what you can see is that over a quarter of providers say that they do not stress the importance of HPV vaccine when they talk with parents. The 3/4 that say they do say it's very important, whether or not they're giving a clear message about that is still yet to be determined. As you'll see here. So this is a just slightly different way of looking at these data. We asked providers here in Minnesota directly about whether they think they recommend HPV vaccine as strongly as they do other vaccines. So on the left, you can see in gray for girls, orange for boys, roughly 2/3 to 3/4 say, yes, I recommend HPV vaccine as strongly as I do other adolescent vaccines. But then we have to compare that to what we see on the right side of this chart. Roughly 2/3 of them also say they prefer to offer it as optional. I see a few heads sort of turn, and yeah, it's a little bit of a confusing message. In some ways it makes sense, right? We don't have school entry requirements for HPV vaccine, so on a fundamental level it's optional for school entry. But this could really translate into a mixed message for parents. What we find is that providers may offer a gentler recommendation in order to build rapport and trust. That's how they describe it. For example, I let them know I'm here for them as a sounding board. I don't take a strong arm approach. I'd rather have them come in and have the discussion than not to have them come in at all. We don't really say this about other vaccines. What we do know from parents is what they prefer in making these decisions is a clear and unambiguous message that the vaccine is important. And that is actually what builds trust and rapport. The fourth quality that we've looked at is urgency, and that is really recommending vaccination the same day. So don't miss that opportunity while someone is in the clinic to do it, especially as young people receive health care less and less frequently as they age. Over 50% of providers say that parents frequently request to delay, defer the vaccine, or refuse. And over 40% say that they themselves offer to vaccinate at a later visit or give them a choice. What we find, though, is that delaying does lead to non-vaccination. It makes sense. We have a current study where we're looking at sort of trends, trajectories of what happens after someone refuses the vaccine. About 40% of those do go on and get vaccinated, so we also need to be recommending again and again every time they come in. But they're much less likely to get the vaccine in the long run. A little bit of qualitative data to fill in what urgency looks like. So providers say, well, it's fine if they want to wait and talk about it more. We had a couple of providers express this. I delay pretty much everybody. To me, it's just not a problem. And I'm flexible about, let's get this started sometime in the next year. Over and over again, we hear providers say, why don't you think about it? And we can talk about this later. So at this point, we have evidence that these four qualities are really best practices. How we teach them and how we translate those into practice is something we're still working on. But there are some other studies that point to some promising practices, and I'd like to point those out as well. The first of these promising practices I'd like to highlight is about communication style. And this is something many people are going to be familiar with. So early work by Doug Opel in Seattle and others regarding childhood vaccines identified two basic different ways of talking about vaccines. And on the one hand, there's this presumptive, and that's really what Noel Brewer at UNC calls an announcement style. So we have some shots to do today. This is a platform. This is what we expect young people to do. We have shots to do today. And then there's the participatory style. So what do you want to do about shots today? Not surprisingly, wow, the presumptive style is less common. It was much more effective and much more efficient than beginning the conversation with a question. The quality of recommendation was higher among clinicians who offered this sort of presumptive recommendation. Next one I want to talk about is concomitants, and basically to recommend it in the same way and at the same time as other vaccines. It is safe to be administered along with other vaccines every time a young person comes in and gets vaccinated for Tdap or meningococcal or flu vaccine. We have missed an opportunity to vaccinate against HPV. We also really want to stress this idea of a guidelines-based rationale. This is tied in a little bit to the idea of risk, but really focusing on what's routine versus what's required. I mention this because there are a lot of ways that people recommend the vaccine that actually can undercut their recommendations. So they might be thinking they're making a strong recommendation. I want to look at some of those qualifications they might make. The most common qualification providers make is that it's optional, or they start off by talking about what's recommended for school. So the ones that the school is going to require are Tdap and your meningococcal. The HPV, the school's not requiring, but we are offering it to you. Automatically, so this provider has made a recommendation offering the HPV vaccine, but has undercut that recommendation already by comparing it to vaccines that are required. So another example. I'll kind of give you the spiel here. And if at the end of it you still want to think about that's just fine, we'll defer. Leading off with the idea that they can defer the vaccine versus waiting for a parent to ask for it. They've already planted that seed. These are really common. There are a few different studies right now out of Greg Zemet's group that are looking at recorded conversations, and they hear things like this over and over again. Oh, I want to, one more comment about undercutting, and it's a message we're testing right now that I'm super curious about. We hear providers say, this is such a cool new vaccine. It prevents cancer. It is a breakthrough. And to us, that's really cool. To a parent, perhaps not as much. So a way that they're thinking they're making a strong recommendation, but that recommendation practice may be undercutting, really communicating the importance to a parent. So the last of these sort of indicators I wanted to talk about is using a cancer prevention message, and that's not surprising. We see it everywhere. HPV vaccine is cancer prevention. The data I'm showing here are data actually from a study in 2009 that we did a factorial experiment looking at vaccine message framing. And what you can see here is that if the vaccine is framed only as genital warts, which no one has ever framed the vaccine only as genital warts and talking to a provider, but when they're talking about it being an STI vaccine versus a vaccine that prevents cancer, acceptability is much lower. So these are data that stress the importance of cancer prevention. And you can also see that in more recent advertisements that are available that are looking at both boys and girls and really stressing cancer prevention message. So, what do these look like in practice? I'm going to show you a couple of examples of what these could look like, and because I'm not a clinician and because I haven't tested these specific messages, I want to be clear, I'm not saying this is what someone should say word for word. I want to use these to illustrate these principles and show how they come together and how efficient this approach can be. Okay, so the statement I'm going to sort of tease apart here is now that Harry is 11, he's due for 3 shots that are important for all kids his age. These will help protect him from meningitis, HPV-related cancers, and pertussis. With "you're okay," we'll give these at the end of the visit. Pretty quick, pretty straightforward, simple message. Within it, we see this idea of timeliness, offering it at the target age range. We also see that they're communicating consistency. Not only are they being consistent with offering it to all kids in that range at their practice, but letting the parents know that this is about all kids his age. There's a strength of endorsement by saying it's important and also by the way the statement itself is communicating it. And urgency. We're doing this at today's visit. Looking at those more promising practices, we can see concomitants, right? So we've got it, meningitis, HPV, and pertussis all wrapped up in the same recommendation, all wrapped up in the same sentence. It's about the guidelines-based rationale. He's due. It's at this age. Here's another variation on the same theme. This is just illustrating the announcement style, right? So I see that Hermione just turned 12. There are 3 vaccines we give kids her age. Today, she'll get meningitis, HPV, and Tdap vaccines. Even shorter. So a final note, and Noel Brewer's lab at UNC has been testing this particular variation, is really stressing the importance by putting HPV in the middle. We so often put it at the end, right? So, we're going to have Tdap, meningococcal vaccine. Oh, and there's HPV, like we saw in a couple of those quotes. By putting it in the middle, we're really helping it to be part of this package of vaccines that all young people should receive. So I recommend, I acknowledge that, it's not just about an initial recommendation. What we do see is that a stronger recommendation kind of heads off, the best defense is a good offense, heads off questions from parents and heads off having a long conversation. But other times questions do come up, of course. For one, communication is just not, it can be in response to parent questions. So while there's growing evidence that initial recommendation can reduce hesitancy, that doesn't mean parents won't still have questions. Indeed, many so-called hesitant parents actually go on and get the vaccine for their child at that visit. We have a lot of data on what parent concerns are, their main concerns, or their main reasons for not getting vaccinated, not getting their child vaccinated, which I show here. I'd like to point out, not getting a provider recommendation, even parents say, is a reason they didn't get the vaccine. Well, the one that we all think about, because my child isn't sexually active, it's actually one of the lower reasons. And these data are from 2013. This percentage is actually lower now than it was. But there's more this idea of it's not necessary, concerns about side effects. They say it's a lack of knowledge. We don't actually see that they don't score well on knowledge tests. But so that there's a general idea of uncertainty about the vaccine that we can address. So one of the things I have recently come to embrace is that we have a lot of great tools out there that we just aren't using effectively. I used to not be very positive about some of these tools because they're not all evidence-based. And as a researcher, I want every message to be tested. But the CDC has actually, what it turns out to be, is a great resource around some very brief statements that someone can use to address about 20 different concerns that parents may have. What we see across those is at the end of each of them, what do? They end with a recommendation, and that's why I recommend your child get HPV vaccine. So it's one thing just to delve in and address concerns, but to not leave that hanging, to always end those conversations with a parent with your clear recommendation. And if they don't end up getting the vaccine that day, making a plan to follow up at the next visit. And that follow-up conversation is incredibly important for them getting vaccinated as they move forward. So the President's Cancer Panel report, which came out in 2012, identified 3 really important strategies for increasing vaccination uptake in the US. So reducing clinical missed opportunities to make recommendations and to make a good quality recommendation like we've been talking about, to increase acceptance of HPV vaccine among parents and young people, but also among providers themselves, and to maximize access. So I recognize that this communication, the interpersonal communication that happens within a clinical visit is not the only thing, and we've been doing work in other areas as well. I want to end by making a few other recommendations about what these may be. So beyond communication, there's recommending at every visit. It's not contraindicated. If someone comes in with a sore throat, they can still get vaccinated. So all those opportunities we have to offer the vaccine at other types of visits. And then a consistency of messages across the healthcare team. Parents have often had a conversation about vaccination with someone before they go in with the clinician. I was presenting at the statewide immunization conference at the beginning of September, and there were a number of front desk and office staff who were like, well, I have parents who say, what are we going to be doing at that visit? And so they are going to be the first person to be saying, and that day, There are going to be 3 vaccines your child is due for because they're coming in when they're 12. And so really making sure that there's a consistent message across the team. We have some data that we haven't released yet that does suggest that parents do receive different messages. So they might hear one thing from a nurse, go in and see a provider and get another message. And so making sure those are much less likely to vaccinate even if someone was offered a strong recommendation. A really simple practice that people can do is before that parent leaves the office to go ahead and schedule in their follow-up visit. Much more likely to follow through. We have a huge problem with getting all 3 doses within the recommended time frame. Most kids don't end up getting the 2nd dose until the next year when they come in. So really going ahead and scheduling those follow-up visits, implementing a reminder recall, doing measurement within our own clinics about how we're doing and how we can improve. Vaccination registries are another important piece. We actually have a pretty good one here in Minnesota, but it's not coordinated across all different types of providers. And especially when we look at follow-up visits and the possibility of using alternative settings to facilitate completion, they're often not a part of the immunization registry. So on that point, and at 40 minutes, I'd like to close and open it up for any questions.
So young men in their 20s missed out on the initial push.
Yes.
So why stop at age 26? Why not say all young men in their 20s should be vaccinated? Or 30s for that matter.
Or women.
Right.
So why do we stop at age 26? Because at a population level, so many people have been exposed at that point that we no longer have the same population benefit. There are other countries that still recommend administration later, and I've received, even not as a clinician, I've received inquiries from people saying, I've never had sex, I'm 30, would you still recommend? I said, talk to your provider, first off, not to me, but that if someone hasn't been exposed, it can obviously still be effective on an individual level, but at a population level, not. Yes, Jeff.
So early on in the talk, you showed vaccination rates by area of the country, and the South and the Rockies were underrepresented. So 2 questions. Does that parallel vaccination rates for other other diseases? And then are the reasons for not vaccinating the same in those areas as they are across the rest of the country?
That's a great question. So it does parallel the sort of trends we see in uptake across other vaccines. So we have lower levels in the South. I'll also note fewer school entry requirements, for example, in Mississippi, where I can speak to. So those are other things that support that we see regional differences in. So we do see similar trends in those vaccination uptake. As far as their concerns about the vaccine, there's similarity in that more concern about side effects. Obviously not the same concerns around my child isn't sexually active or shouldn't be due for this vaccine yet. And Mark, would you like to, did you, I thought you were ready to jump in. Yes.
Thank you. Thank you for the great talk. By the way, Mississippi, I don't have to tell you, is one of only 2 states that has no religious or philosophical exemption for school vaccines. So I guess one might argue that if this was mandated for school attendance, rates would go way up in Mississippi. But anyway, my question is something else. Early in your talk, you talked about the non-16, non-18 HPVs and the risk of cancer. And I would just wondered if you had if you could comment on that a little bit more. The story was always so elegant, right? That 16 and 18, it's E6 and E7 oncoproteins that bind PRB and P53, and that E7 in particular has this really, really high affinity for PRB, and it makes it different than all of the other HPVs. And that's what we learned in medical school, but it's actually more complicated than that, right? So they're non-16, non-18 HPVs that also are associated with cancer, presumably by different mechanisms than PRB and P53. So I just wondered what the current thinking was on that.
You may actually, given that that's a little, since I've primarily focused more on behavioral and psychosocial constructs, I would be interested to hear what your thoughts are on it.
I don't know the answer, that's why I asked. But I I think it is important. I guess in the bigger picture, we need to remind families and parents that we already give an anti-cancer vaccine, right, which is hepatitis B vaccine. And I don't know if you've studied that or if that's a message that resonates at all with families or not. So anti-cancer vaccines are a part of clinical care already.
Thank you.
Hi, Annie-Laure. Thank you for that. That was great. You mentioned the opportunities in non-clinical settings to do immunization, and in this country we don't do a lot of that.
Right.
Can you talk a little bit about where the research is with how effective that might be, or what the policy issues are that are keeping us from doing it?
Sure. I can talk about a couple of different aspects of it. Not necessarily how effective it is at increasing vaccination from where it is, but I can speak to parents' acceptability and young people's acceptability of getting HPV vaccine in other settings. And the two primary settings that people have explored are pharmacies and schools. And in schools, that could look a couple of different ways. It might be through a school-based health center, so a freestanding center within a school, or it might be through some sort of mass immunization program, which typically doesn't happen. It has been tested in a couple of unique settings, but probably not something that's going to be rolled out at a larger level. But parents are really supportive of that, but primarily for follow-up doses. It's not where they want their child to receive that first vaccine when we ask them about it. But they have high levels of acceptability. They do worry about those settings with coordinating records, which speaks to the importance of those immunization registries. Another setting that we have also been exploring is using dental offices as vaccination because of the association with oropharyngeal cancer, even though the vaccine isn't necessarily indicated for that purpose. Is it an opportunity to educate about HPV? We're already doing an oral cancer screening in most preventive visits. So there are other settings. There are a lot of challenges to those settings, both at a policy level, as well as just getting parents to buy into the idea that you go to your dentist and you get vaccinated, or you go to the pharmacy and get vaccinated for something besides the flu vaccine. But people are still examining it, and I think if we move to a shorter, more streamlined vaccination schedule with 2 doses, it may be less necessary to be exploring those. The other barrier to those I wanted to bring up is also just stocking and keeping that vaccine in order to be able to deliver it. It's a real challenge, and it's one that we've seen with pharmacies. To have it on hand to be able to administer. It's an expensive vaccine. Its storage is different from other medications, and so there are a lot of challenges, both practical and policy. Thank you.
Thanks very much for the talk. I guess my question has to do a little bit with this day and age of how parents communicate and challenges that we as providers have to deal with Facebook posts. Yep. And parents on the internet reading different things in regards to some of the quote-unquote controversies around HPV vaccine that have been noted internationally and maybe nationally. Mm-hmm. And so I wonder if you could address the idea of, would it be better for us to head these off up front when we're talking about what vaccines they're due today, or wait until that's asked to us as a question for parents that maybe have concerns about the side effect profile and where those concerns are, how they're founded in, and how we address those concerns?
Thank you. This is a great question, and it's one we've examined a little bit, but I will start by saying, one, I appreciate the air quotes around controversies. It is a very safe, very effective vaccine, and it prevents cancer. Doesn't seem so controversial when we put it that way. So I love that. I would also say that definitely not making a strong, unambiguous recommendation and letting parents ask questions is going to be the most effective way at achieving uptake. Using those qualities that we talked about, the different indicators of a quality recommendation practices we talked about today, we can respond, again, always ending with a recommendation. We actually did some work looking at using the internet as a source of information and how is it associated with vaccine acceptability, and not so much. It is still that same very small group of parents that have those concerns, and I think that we feel hypersensitive to it, and that we can play into making it more controversial than it is by bringing it up, being, well, you may have heard some bad things about this vaccine, but I want to recommend it anyway. And so, thank you for the question.
Thanks, really enjoyed this. from a state legislature standpoint, in Minnesota or in other states in the country, is there any movement towards including this as part of the a required immunization schedule for school?
For school, you know, I have strong opinions about this one. I really think that when the vaccine was rolled out, we shot ourselves in the foot, or more importantly, pharmaceutical companies shot itself in the foot by trying to push school entry requirements when it was still only available for girls, before it was even available and people were familiar with it. So I think that we have tainted those waters, so to speak. People have a harder time also with HPV vaccination as a school recommendation because of its mode of transmission, which we have made a big deal about, in part, again, because we rolled it out for girls first, then boys. There's some interesting work actually being done by a researcher here, Sarah Gaulis, who's in health policy, examining whether or not it might be time to revisit that conversation. It's been a decade now. So most of those efforts haven't been successful. And each year things come up. The ones that do exist have very generous opt-out policies, and so they're just not very effective. But I do think that the time's come to revisit the question.
So in Minnesota, so I know there are certain areas that are protected by law that adolescents have autonomy and confidentiality in. You know, most, you know, screening for STDs, treatment of STDs are some of those. What I've heard is the HPV vaccine, though, all other vaccines, you know, a parent would have to be there and consent, though. You know, the HPV vaccine falls in this gray area in my mind.
Yes.
And I think for what I've heard is it's not covered under that law. Can you speak to that at all?
I can't speak specifically to Minnesota, and I would actually look to some of my incredibly savvy pediatrician colleagues here, but I can say that some people have kept that area gray on purpose. Kind of provides a loophole that we can use to vaccinate. And we're really talking about older adolescents at this point. It's very rare that it's a 12-year-old coming in without a parent to ask for a vaccine. But I can't speak exactly to Minnesota's legislation on that. Can anybody else here? We have great resource within this very room on this topic. If you want to let me know, I'd love to get back with you about that. It's something I've been meaning to look into since I got here.
No, on a personal touch level, there are a few things that I think are often helpful. You know, one of them is, do you know anybody who's had cervical cancer? And those are the people that, I mean, you never have to say anything. You say HPV, they say yes. You don't even have to say anything more. There's another just interesting one, which is, but my child will never have sex.
Oh, yes.
You want grandchildren? Yeah. But
and so one of the messages that we do test, just jumping off from that last one, is that this idea of like, most people are going to have sex. Someday we all want our kids to grow up to be sexually healthy and to have fulfilling relationships, and sex is part of that. Even if your child waits, their partner may not. But we aren't sure the best way to communicate that to a parent in a way that doesn't bring up risk again. So.
And the last one, since it comes up reasonably frequently, is isn't this licensed to my 11 or 12-year-old to have sex? Has anybody actually queried 11 and 12-year-olds about what they think about this?
We most certainly have. Thank you for asking. These are all great points, and it does get at the subtlety of a lot of these conversations. So, no, kids don't interpret this as licensed to have sex. We have looked and don't see greater sexual disinhibition. We see safer sexual practices among young people who've gotten the vaccine. Why that would be, I don't know. Perhaps it led to a conversation later with their parent about what the vaccine protects and safer sex. We're not exactly sure, but there hasn't been more likely to have sex at an earlier age or to have greater risk-taking later. So it is very well supported empirically that there's no sexual disinhibition. But even in our direct just asking young people, they don't perceive it that way, just like they don't perceive taking a class on physics as they're going to become a rocket scientist or go to the moon. Yes.
Thank you for talking about this hugely important topic and also for giving us examples on how to approach in the clinical setting. My question was, have you noticed similarities and differences with flu vaccine uptake, and what can we learn from between the two of them?
I haven't studied flu vaccine uptake. I can talk about levels of uptake, but I haven't studied those correlates and what's psychosocially associated with flu vaccination. So unfortunately, I can't speak to that. But again, I would be really happy to look into that. Any other questions? Well, thank you very much. This gives me some good ideas of how to move forward. I appreciate your comments.
You have been